Thank you everyone for joining. I apologize for some of the technical difficulties. Welcome to the Guidelines International Network North America webinar series. My name is Tracy Wolf and I'm the moderator for this webinar. I'm a physician trained in family medicine and preventive medicine and have worked with the U.S. Preventive Services Task Force for over 12 years, most recently as the Associate Scientific Director, and I'm currently on the GIN North America Steering Group. Thank you for joining us, and welcome back to all who attended the GIN conference in Manchester and joined us at our regional meeting there. I'd like to take this opportunity to thank the American Academy of Neurology for kindly allowing us access to their webinar platform today. We appreciate your generosity. Before we get started with today's talk, I would like to briefly share some background on GIN and GIN North America. GIN was founded in 2002 with the mission to lead, strengthen, and support collaboration in guideline development, adaptation, and implementation worldwide. I encourage you to visit the website www.g-i-n.net for more information. GIN North America is a regional community of GIN users, developers, and researchers in North America who are interested in the clinical guideline field. For more information, visit the website. In our 2018 webinar portfolio, in addition to featuring ongoing and completed research, we continue to feature a number of webinars on innovative methods of guideline development. Today's webinar is a novel tool for guideline developers and systematic reviewers, modeling for guideline development. Today we have two speakers who have extensive experience with the use of modeling in guideline development and health policy. First, we have Dr. Diana Petiti, who will give an overview on models, how models can be used to inform guidelines and policy, what are the main types of models, when are models useful, how to assess the validity and recognize the limitations of models to inform guidelines and policy. Dr. Diana Petiti has degrees from Cornell University, Harvard Medical School, and the Berkeley School of Public Health, and is board certified in preventive medicine. She has authored more than 240 publications in journals and 2 books, one on meta-analysis, decision analysis, and cost-effectiveness analysis, and another titled Applied Epidemiology. She has served on numerous national and international committees, including the U.S. Preventive Services Task Force as Vice Chair, the Institute of Medicine's committee that produced the report, Knowing What Works in Healthcare, a Roadmap for the Nation, and the Institute of Medicine's National Cancer Policy Board as Vice Chair. After Dr. Petiti presents, we will hear from Dr. Eric Foyer, better known as Rocky, on his work with guideline makers and policymakers through the program he leads, Cancer Intervention and Surveillance Modeling Network, or CISNET. Dr. Foyer received his PhD in biostatistics from the University of North Carolina at Chapel Hill. Since 1999, he has been Chief of Statistical Research and Applications Branch, Division of Cancer Control and Population Sciences at the U.S. National Cancer Institute. Dr. Foyer is the NCI project scientist for CISNET, a collaborative group of investigators who use simulation modeling to guide public health research and priorities. He is the author of over 200 papers in the areas of cancer control modeling, statistical methods for the analysis, interpretation, and presentation of population-based cancer statistics, development of new cancer progress measures, and survival analysis. He is a co-developer of JoinPoint, a methodology and associated software that is widely used for the analysis of cancer and other health trends. Dr. Foyer is a fellow of the American Statistical Association and was awarded the NIH Director's Award for recognition in advancing statistical methods to interpret national cancer statistics. I'm very happy to have these two distinguished speakers to join us today. In terms of webinar logistics, I'm hoping that you can hear me. Please let us know if you can't hear us. Please note that all attendees were muted upon entry to the webinar to ensure a smooth recording of the session. Please do not unmute yourself. And please do not place us on hold. If necessary, please hang up and dial back into the meeting when you are ready to rejoin. We have allotted time at the end of the webinar for questions at the end of both presentations. Throughout the presentations, please submit your questions via the chat box in the lower left of your screen. I will convey your questions to the speakers verbally after both presentations. I apologize in advance in case we are not able to answer every question submitted. If you have technical difficulties with using the webinar, please click on the Help button at the top of your screen. The slides and recording of this webinar will be available on the GIN website next week. And look for communications from us for upcoming webinars. We welcome suggestions for future webinars, and please send us to us at guidelines.northamerica@gmail.com. And without further ado, I welcome Dr. Petiti to get us started.
Great. I am going to today give you an overview of the use of models in guideline development, and I have a number of specific objectives, which first of all, Tracy has already gone over these. I'm going to first of all describe how you can inform clinical guidelines and policy. We're getting a lot of background noise on my phone. I'm going to frame this.
If you're not speaking.
I'm sorry. I can call back, but I can't do anything about the phone if it's not going to. That's better. Whatever happened, I think, has gone away. I'm framing this talk in terms of decision theory and decision science. In the day-to-day practice of medicine, people make decisions, policymakers make decisions, and one of the ways that there's an ongoing need to continually figure out how to make good decisions. Some of the general approaches to improving decisions is to replace a person with, obviously this phone is not doing too well. To replace a person with a group, and that's what guidelines are. But another way to improve decisions is to try to replace a person with mathematical model. Clinical practice guidelines, there's widespread agreement nationally and internationally that guidelines should be based on systematic reviews that consider the quality, quantity, consistency of the relevant evidence. However, in practice, findings from systematic reviews may not provide the information that is important in clinical or public policy settings. For example, and in this
The conference is now in listen-only mode. The conference is no longer in listen-only mode.
Screening guidelines may need to in cancer screening guideline, panels may need to decide whether to recommend screening for a specific cancer.
Hi, Dr. Petiti. We can't hear you. Are you speaking?
I can hear massive amounts of feedback, so I stopped for a minute to see if I could get a better phone signal. In practice, one way to bridge the gap between primary evidence and guideline development is by using models. This information, and this comes from a paper by a group of modelers, Habema et al., and was published in the Annals. One way to bridge the gap between the primary evidence is to apply new or updated information on disease risks and treatments. One of the examples that I give here is that estimates of the mortality benefit from breast cancer derived from trials that started many decades ago. and advances in breast cancer treatment have decreased disease-specific mortality and potentially reducing benefits of early disease detection. Models can project outcomes by using more recent information about the effect of new treatments. Models can explore a range of possible intervention strategies that are not examined in trials. For example, randomized trials of breast cancer screening have examined only a small number of potential screening strategies, starting ages of 40 or 50, ending ages of 69 or 75, and annual or biannual mammography. Models can assess other potential screening strategies at many different ages to start and stop, clarifying the potential trade-offs of different strategies. Models can bridge this gap by assessing important benefits, harms, and costs over the lifetime of a population, thus extending beyond the published studies to evaluate measures of harm and benefit not addressed in primary evidence. You can evaluate study time horizons by extrapolation, and models can be used to examine costs and cost effectiveness. They can project outcomes for populations not including in trials or in situations where primary evidence was gathered, other than those where primary evidence was gathered. For example, in other countries, in people with comorbid conditions. For example, for colon cancer screening, there have been a number of modeling studies done by the CISNET group that explore optimal colonoscopy screening strategies according to age and race. I'm going to talk about the main kinds of models that have been used to inform clinical practice guidelines and policies. But first I'd like to say generically, what is a model? A simplification of reality that attempts to capture the essence of a phenomenon with the minimum level of complexity. Models, more formally, are mathematical frameworks that integrate available evidence to estimate the health consequences of alternative intervention strategies, and there are many classes of models with different goals and methodological approaches. They address what-ifs and make many assumptions. The models that have been used most often in healthcare, described according to the ISPO framework, are state transition models, discrete event or state transition models, including decision tree models, Markov model, cohort simulation, and other kinds of micro-simulation. Risk stratification models have played an increasing role in guidelines. However, we're not going to talk about those now. State transition models have a number of carefully defined formal elements. I won't read the slide and tell you what they are, but I will give an example here, which is a graphical depiction of a state transition model for malaria. I'm going to briefly mention other kinds of models for completeness. Discrete event simulation models have been used for decades in physics and engineering, and they're often used to try to optimize operations in situations where resources are constrained. In discrete event simulation models, a question is posed and simulation provides the answer. Here are some of the core concepts of discrete simulation models. Many applications in healthcare involve attempts to optimize operations related to workflow and queuing. For example, how best to staff an emergency room in order to avoid lines. I'm not going to read this slide, they'll be available, but here are some specific published examples of the use of discrete simulation in medical care. Dynamic transmission models are used to model the epidemiology of infectious disease and to evaluate potential effects of interventions used to modify the course of disease. Here's a recent example from a paper looking at H1N1.
I'm sorry, there's a lot of feedback. I apologize. If you're not speaking, if you could mute. And Dr. Petiti, there's a lot of feedback. I'm wondering if you could mute your computer, or that might help the speakers and the microphone on your computer. That might help.
Let me go do that. I usually virtually always have my computer on mute, but my computer is muted. I'm going to see if there's something else I can do to...
I apologize for all the technical difficulties we're having, everyone. Please stay tuned. And if you're a presenter and you're not speaking, if you could mute your phone, that would be helpful. There's some background noise.
I'm going to identify some of the situations where models might be most useful and when they're not likely to be useful. This information is taken from the U.S. Preventive Services Task Force own guidance to itself and appears in its procedure model. The U.S. Preventive Services Task Force considers that candidates for decision modeling are generally recommendations that are A, B, and C recommendations. That is, recommendations where there's confidence that there is empiric evidence of net benefit. For all of those of you who aren't familiar with the U.S. Preventive Services grade definitions, an A definition is one where the U.S. Preventive Services recommends the service. There's high certainty that the net benefit is substantial. A B, recommend the service. There's high certainty that the net benefit is moderate, or moderate certainty that the net benefit is moderate to substantial. And a C recommendation is a recommendation where the service should be selectively provided. There's at least moderate certainty that the net benefit is small. Again, the U.S. Preventive Services Task Force has written guidance for itself. It's primarily warranted when there is an outstanding clinical question about how best to target the clinical service at the individual or program level, and it is highly unlikely that the systematic review can confidently determine the magnitude of net benefit, particularly as it varies among important pre-specified subpopulations. There's also guidance from others about when a model is not useful. Modeling is not very useful when one intervention or strategy is a clear winner, although I think many of the participants in the conference call recognize that it's not very often that there is a clear winner. And it's not very useful when there's a scarce amount of information. The U.S. Preventive Services Task Force also has laid out situations where it considers that models should not be used to bridge a gap in the analytic framework where evidence is insufficient by making assumptions about or using unreliable data. This is an I statement. A model cannot fill in data where there's an I, with one exception, and Dr. Foyer will be talking about this in more detail. When there's insufficient empirical evidence to determine when to start or how long to continue delivering a clinical preventive service, how frequently to repeat the service, and the best or equally appropriate choices among different ways of delivering service when it's unlikely that clinical trials will be done. It's really important, and hopefully Dr. Foyer will talk about this in more detail, to consider that feasibility is a very important consideration when deciding whether to use decision modeling. Feasibility considerations are the time that might be added to the process, the availability of funding to tailor the process, the expertise of personnel who need to be involved in working with modelers, and the accessibility of pre-existing off-the-shelf modeling. One of the most important considerations in whether to use models is whether or not the models that are used are valid. If a model is not valid, then any conclusion derived from it are really of no value. ICE4 has laid out a specific framework for looking at model validity and considers that there are many aspects of model validation, including face validity, whether or not where experts evaluate the model structure, data sources, and assumptions to see if they make sense, verification, where experts check the accuracy of coding, cross-validation, where results are compared with other models analyzing the same problem. External validation, where model results are compared with real-world results, and the predictive validity, where model results are compared with prospectively ascertained data. I've provided several examples.
I'm sorry to interrupt you, Diana. There's a lot of background noise. It sounds like a lot of people have not muted their phone. If you could please mute your phone if you're not the presenter, that would be really, really helpful. It's hard to hear what Dr. Pessotti is saying. I apologize, Dr. Pessotti.
Yes, I can hear it myself. I feel like I'm talking over an ocean of noise. This is a slide which shows an example of cross-validation and external validation simultaneously. These are 5 different models, simulations of...
Oh, really? Yeah.
Boy, I just can't...
Please, if everyone could mute, we can hear conversations and other things. Please mute if you're not speaking.
Mm-hmm.
And determine who it was making the noise. You know what the operator would do?
Really?
I hear a conversation going on in the background, and it's essentially impossible to talk over it.
That's the way to do
Yeah.
Yeah, I saw it says Area Campbell talking.
But it costs that operator to do that.
Mm-hmm.
I think I'll keep trying. This is an example of cross and external validation.
One of the problems is that if you log in through the ReadyTalk, there is no way to mute yourself. But if you call separately on direct phone lines, then you can mute yourself.
Worth us waiting a second for people to call back in? Because it seems, would that be worthwhile? Just people calling in the regular number then?
Yes, that would work better. It seems like there's a lot of background noise. It's difficult to hear.
Or maybe we should pause just a minute or two and let people hang up if they, you're saying if they called in through the computer to hang that up and then call in through the phone number, is that correct?
That's what worked for me.
It's gotten a little quieter.
Thank you, everyone. Dr. Petiti, would you like to continue?
Yes. Once again, using a CISNET example, here's an example of simultaneous external validation and cross-validation. This is from one of the projects done by CISNET, and I think Dr. Foyer will be talking about it a little bit more. It shows the solid line shows the actual results, the percentage of the mortality difference as between chest X-ray versus CT that was found in the National Lung Cancer Screening Trial, and the estimates of what that difference would be based on the 5 lung cancer models that were used by the U.S. Preventive Services Task Force in order to make its recommendations. This is another example of model validation. This is a study that was done of a cardiovascular disease model, and it shows how the model, which is in the blue line, reproduced information from the Framingham Health Study and from ERIC, and from, this is actually an external validation study. I did want to talk a little bit about some of the limitations of models used to inform guidelines. First of all, one of the major problems is there are not many off-the-shelf models, and it's extremely demanding and expensive to develop a good model de novo for a guideline project. Even if there are off-the-shelf models, it's rare that the model has been used to address specific issues that the guideline developers might want to address. And even if there's an off-the-shelf model, the modelers may not be interested in working with the guideline group or may not have time to address the issues the guideline would like addressed, or the guideline would cost too much. Sometimes an off-the-shelf model isn't good and shouldn't be used. I want to talk about one of the ways that that's to overcome some of these limitations of individual models And that's by engaging in collaborative or comparative modeling, where two or more entities that have developed a model for a given condition collaborate to address the same question or questions pertinent to the clinical policy. On the other hand, collaborative or comparative modeling has some limitations. It can be resource intense and can add to the development time. When informing guidelines, it requires a high level of coordination between the guideline developers and the modelers. And with great relief, I'm going to turn this over to Dr. Foyer. And hopefully he'll be better on his phone.
Yeah, I don't know how. Could everybody, I hope people could hear me. Okay, let me start. So thank you very much for the invitation to talk. I'm going to talk about simulation modeling and cancer control planning, but specifically a project that we have, a consortium that we have run here out of the U.S. National Cancer Institute called CISNET, which is NCI's consortium for population modeling to guide public health research and priorities. So CISNET is the Cancer Intervention and Surveillance Modeling Network. It's an NCI-sponsored collaborative consortium. From a grant mechanism point of view, it's called a UO1 mechanism, which means the grantees work with each other and also work and integrate in with some of the priorities we have here at the National Cancer Institute. So it's a group of modelers in 6 cancer sites: breast, prostate, colorectal, lung, esophagus, and cervical cancers. It was actually formed way back in 2000, but some of the cancer sites, most recently esophagus and cervical, joined the consortium more recently. The overall purpose is to synthesize trial, epidemiologic, and surveillance data using simulation modeling to guide public health research and priorities, and help to address what might be called the formidable and ever-growing gap between the rapid pace of innovation in cancer research and our ability to efficiently harness it to improve population health. With the idea that lots of things are coming at us, how do we sort of integrate them into the population in ways that are efficient and for the in some sense efficient for in the population. Well, it's good to fix ideas. You could simulate a lot of different things. What are we actually simulating in this context? So in CISNET, kind of generically, we simulate individual life histories with respect to the year a person is born, the development of risk factors for cancer or their background risks for those born in specific years, then the development of precancerous lesions, for example, polyps for colorectal cancer, Barrett's esophagus for esophageal cancer, the initiation of cancer, and then the rate of growth of cancer. And I highlighted these in yellow. They represent collectively the preclinical natural history of cancer that's not observed directly, but could be indirectly inferred from other data, from different data sources. Then the diagnosis of cancer through symptoms, basic treatment in some base year prior to treatment advances that would be modeled specifically, death from cancer or other causes, and then all this is calibrated or fit to as many data sources as possible. Sometimes we call it multi-target calibration. We fit to many data sources at the same time. We then intervene on these individuals with advances in prevention, screening, and treatment, which changes in their life history. Of course, the advantage of modeling, unlike real life, is that you could have parallel lives both within and without the intervention. So we run the models, say, twice or many, many times for different types of interventions. And then we sum together these individuals. So it's a micro-simulation. We're simulating individuals. We sum together these individuals. The models can represent what happened under real or hypothetical scenarios and the impact of each intervention by comparing runs. An outline of what I'm going to talk about is what sometimes I call the 5 tenets of CISNET modeling. I don't think individually any of them are unique, but perhaps having this nucleus of these 5 tenets is somewhat unique in the world of modeling. Then I'm going to give 3 examples of CISNET work. Some of them pertain more or less to guideline setting, but I thought I'd just give you a variety of examples. And then just a short little piece on where the models fit in the evidence hierarchy, because I think evidence review groups are always thinking about that. That's kind of a difficult question. So first, the 5 tenets of CISNET modeling. And the first is what might be called flexible, broad-based disease models. And I give an example here colorectal cancer, a colorectal cancer model, which is a kind of a mathematical formalism of the process of developing adenomas and then developing cancer. And I just want to say that there's a term sometimes used for modeling that's called one-off modeling. That's where you develop a model for a single purpose, and then then that's the end of the model. You develop the model quickly, use it for a single purpose, and then go on from there. We're kind of just the opposite. We're the other end of the spectrum. We use models for we develop these models over many years and use them for many different things. So just as an example, somebody has no lesion in the general population, and then people develop adenomas. Those adenomas grow over time. Some adenomas then become preclinical cancer. The preclinical cancer could progress and at some point become clinical cancer, and then the person could die from colorectal cancer or other causes. We model, and then just to say, these transitions are not observed. These are not observable things. We don't know in people's bodies, how many adenomas are growing, but we can look at various data sources. For example, autopsy studies where people die from other causes, and then they section their colon and see how many adenomas they have. From screening studies like colonoscopy studies, from our population-based incidence studies and U.S. mortality, and really any other data source that we can find. And what we do is then we intervene on this by changing the transition rate. For risk factors, we change the initiation rate of adenomas or the growth rate of adenomas. For screening, we find adenomas early and remove them. It's kind of unique in colorectal cancer that we could prevent cancer, or we find cancer at an earlier preclinical stage, and then they get on a better. They're an earlier stage, and they could bet on a better survival curve. And then treatment, where based on clinical trial evidence, we put people on a better survival curve. These models are not that difficult to modify when new technologies come along. So, for example, when virtual colonoscopy or colonography or virtual colonoscopy came along, we had to get some of what's called the operating characteristics of that technology, sensitivity, specificity, and things like that, and then we could add it to these models. So, kind of as I mentioned, the opposite end of the spectrum is what's called one-off models. These models have been developed over many years. The overall schema then for CISNET is to have intervention modeling. These are common inputs into the models, such as risk factor trends, screening behavior, diffusion of new treatments. And then the heart of CISNET is individual cancer models. These are models of the development of precancerous lesions, the initiation of cancer, the rate of growth of cancer, and then common outputs that we collect, the costs and benefits of interventions. For example, mortality, quality-adjusted life years, overdiagnosis, direct medical costs, etc. And then we add calendar time as appropriate to represent the real U.S. or other populations over time. Second tenet of CISNET is multiple birth cohort modeling. So I've shown here kind of a typical, what some done in some modeling is modeling a hypothetical cohort. Suppose we have people starting at age 30 and continuing to age 79. And what I've shown here is what's called a Lexis diagram: age on the y-axis, calendar years on the y-axis. And people live along a diagonal. Each calendar year, you age 1 year. But I purposely left the calendar year axis empty. I didn't put in particular years because it represents kind of a some hypothetical cohort of people going from 30 to age 79. In CISNET, we do multi cohorts to recreate the actual population dynamics of the U.S. population. So if you look at the red box, suppose we're interested in modeling the U.S. experience between 1975 and 2000 for people ages 30 to 79. Well, then that requires us, if you take those diagonal elements down in this Lexis diagram, it requires modeling birth cohorts all the way from 1895 to 1970. So we have to go back and find rather old data to try and recreate what happened to people in the U.S. or other populations over time. The best example of this is what we call our smoking history generator. And this is something that's developed by the Lung CISNET group. And they've developed this over many, many years to refine this. And it's based on a national survey, the National Health Interview Survey, and those surveys have been occurring all the way from 1965 up to the present. But in each of these surveys, they ask, when did you start smoking? Did you quit? And all those types of questions. And what we get out of those, what we estimate out of those surveys is age-specific initiation probabilities by birth cohort, age-specific cessation probabilities by birth cohort, and also even for people who do smoke, by birth cohort and age, how many cigarettes per day they smoke. You can see, if you look at this diagram, the dramatic differences by birth cohort. The highest birth cohort for men is the 1920 birth cohort for initiation rates. These were men who fought in World War II, so around 1940, 45, and they were handed out cigarettes and just had very high rates of smoking. And you can also see the very large differences between men and women. This smoking history generator has been developed by gender, but then over time they've worked very hard to develop it by other relevant characteristics. They've developed it by race, tried to develop it by race and ethnicity, by income, by education, and also by state in the United States, because many of the tobacco control policies are initiated in different states. And then these probabilities go into something that's called a smoking history generator. In other words, you put in a person's year of birth and then maybe some of the other characteristics, gender, race, socioeconomic status, or something like that, and it simulates for an individual the age they started smoking, if they did, how many cigarettes per day they smoked, and when and if they quit. And then that feeds into the other models. And they've even developed tobacco control policies that change the initiation and cessation rates into the future as a function of different policies. Third tenet of CISNET modeling is sometimes called comparative modeling. So I show an example here. This is an older approach. This wasn't part of CISNET, but it's a kind of a nice illustrative example of 4 independent studies of the cost effectiveness of CT screening for lung cancer. This was in 4 papers, came out very close to each other from 2001 to 2003 in rather well-known and prestigious journals. And they found that the cost effectiveness of CT screening varied widely from these models, all the way from $154,000 per quality adjusted life year saved to $2,500 per quality adjusted life year saved. And if you put these results together, it's really very difficult to make any heads or tails about it, because there's so many differences between these models. These are probably all somewhat reasonable models, but there's differences in the target population, screening frequency, stage shift, assumptions about lead time, overdiagnosis, and sensitivity. And so it's very hard to, sometimes there's a term in economics, ceteris paribus, keeping other things equal. So it's very hard to make any conclusion. And I think unnecessarily it tends to give modeling a bad name. You can get any result you want, especially if you look at these results. So when we started CISNET, we decided to try to use a kind of what we call a systematic comparative modeling approach. We have central questions addressed by groups collaboratively with a common set of inputs and outputs, where reproducibility across models add credibility to the results, and differences points out areas for further study in a systematic way. So sometimes the results, because we have groups of people have to work together, takes a little longer, but we feel this encourages cooperation instead of competition between modelers. And really, in the end run, even though some of the results take longer, it advances the science more rapidly. To facilitate this sort of working together, we've used a certain organization in CISNET. So we use multiple PI, multiple principal investigator cooperative agreements, each focus on a different cancer site. So we have 6 cancer sites. We have 6 grants, each with a coordinating center to coordinate the results, but multiple modeling groups, between 3 and 6 modeling groups. And these are not modeling groups in the same institution. These could be modeling groups, the best modeling groups all over the world. Most of them are the U.S., but we have modeling groups in the Netherlands, and Australia, and other places. So, but it's coordinated together in a single grant so that they could work together in a coordinated way, which is really the way they need to do this comparative modeling. The fourth tenet of CISNET modeling is transparency in model structure, assumptions, and outputs. And I think Diana mentioned that there's kind of many assumptions that go into modeling, and that's inherent in the modeling, but how could we make it easy for people to understand? And sometimes we would show these three dancers. We sometimes call the things we've developed the troika of model documentation. We call it model profiles, model registry, and model stress tests. And I wanted to describe what each of those are briefly. First is model profiles. That's detailed, templated model documentation. And the advantage of having the documentation templated is that the profiles could be navigated by group, so you could read everything about one breast model. But if you'd like to compare the breast models, you could take one aspect of the models and read across the models, so you could better understand differences between them. The next is called the CISNET Model Registry. That's less technical, high-level descriptions of models suitable for consumers of model results or for those collaborating or desiring to collaborate with CISNET modelers. So we have a feeling that there's not one documentation that fits all, and we have to have different levels of documentation for different types of users. The third is something we're working on. It's called model stress tests. And what this does is real differences in the natural history assumptions of models by what we call, quote unquote, stressing the models and examining model outputs. So just to give an analogy, I show a punching bag here. So to find out about a punching bag, you could explore its height and weight, etc. That's the model profiles and model registry. We're describing the characteristics of the punching bag. But you can also hit it and see what happens, and that's what we do here. So, I thought there was another slide that was put in here. Oh well, I'll talk through this. This under development was supposed to not show up. Yet. But if you look through that, what we're developing is something called the maximum clinical incidence reduction is an example measure. And what we do to quote unquote stress the model is we provide a situation where we have at age 65, this is for colorectal cancer, we do a single perfect screen at age 65, and that means it's a perfect colonoscopy, so it removes all polyps and all preclinical colorectal cancer. And then what we do is let the models run and see these curves going up. That you can't see all the curves; they're going up at different speeds, and we're seeing how long does it take to return to the background incidence level, as if the background incidence level is the incidence level if the test was never done. And you can see here that two of the models, called CRC-SPIN and SIM-CIRC, are fairly close to each other, but the MISCAN model is somewhat far away. It's very interesting, and so this is useful for people to understand some of the why you might get differences in model results, but it's also very useful for the modelers, because in response to this, the modelers, they were somewhat aware that they had these differences, but they then found a new data set, which was a flexible sigmoidoscopy study, the FlexiScope study that was being done in the UK, and they were able to get the individual level the data from that trial and use it to recalibrate their models. And after they did that, the three models have come together somewhat. So that's an example of using this, but it's also very nice to use just to show people what's the differences. And we're developing this website. We're going to be using it to highlight differences in natural history between different cancers, but also between different models for the same cancer. Finally, we have additional summaries of models in individual papers. So when we write a paper, we put in a summary table like this that kind of summarizes the models and the differences between them. Finally, and perhaps most importantly, the fifth tenet of CISNET is what might be called outreach and collaborations. And starting with the upper right, I just wanted to briefly give some examples. So the most important thing at CISNET is working with different groups on important problems. So we work with the Centers for Disease Control, Division of Cancer Prevention and Control, in studies to guide CDC in designing new programs or enhancing existing ones. For example, CISNET worked with a CDC program called the National Breast and Cervical Cancer Early Detection Program. That's a program for low-income and uninsured individuals wanting to understand the implications of the switch from film to digital mammography in facilities they use. And CISNET did some modeling that helped them with that. With CMS, that's the Center for Medicare and Medicaid Studies on technology assessments to support national coverage determinations. So for example, what should the reimbursement level be for various colorectal cancer screening tests, such as FIT, the fecal immunochemical test? And through CMS, they have a mandate that you use something called threshold pricing method. So what that says is that the reimbursement level should be set so that the cost effectiveness of FIT is equal to that of the traditional older test, the guaiac-based FOBT test. And the cost effectiveness is established through modeling, for example, quality adjusted years of life saved per dollar spent compared to no screening. And since the FIT test is more effective, a higher level of reimbursement level can be supportive. The high sensitivity guaiac-based test is reimbursed at just under $5 per test, and the FIT test based on this threshold pricing method is reimbursed at just under $22 per test. Another example is with the American College of Radiology Imaging Network for the cost effectiveness of the study for a national CT colonography trial. And then probably most importantly is our work with the U.S. Preventive Services Task Force through the Agency for Healthcare Quality Research and Quality. And I think prior to CISNET, there's always been some modeling I think that's been used with the task force, but I think having the comparative modeling approach and has really helped bring the credibility of modeling together. And so I think it's made the task force more comfortable with using models. CISNET has worked twice, two times in evidence reviews for breast, 2 times for colorectal cancer, 1 time for lung, and then 1 recent time with cervical cancer. So now 3 examples of CISNET work, and the first is an example in lung cancer. There are 6 modeling groups in lung cancer. The coordinating center is Rafael Meza at the University of Michigan, the coordinating center PI. So this is an article from the Cancer Letter. It's a letter that's an independent letter published by an independent publisher that gives people around the country the news of what's going on at the National Cancer Institute and the cancer community. This came out in November 26th of 2010 when the National Lung Screening Trial just came out. And they were talking to Dr. Chris Berg, who was the person at NCI who coordinated this trial. And she said, they were asking her about the trial and who it's relevant to, and she said, my opinion is that one can conclude from the NLST data that 3 annual low-dose helical CTs in individuals ages 55 to 74 with a 30-pack year smoking history can lower lung cancer-specific mortality by 20%. So that's exactly the criteria. That they used to run the trial. They had to pick one criteria, and it was a very expensive trial to run. And then she said, like a good trialist, trialists say that the trial results apply to what's in the trial. She said claims beyond that we're not addressing. We're saying that our data speak to what we did in the population in which we did it. But then she went on to say, well, the CISNET modelers may be able to look at different frequencies of screening, different ages at starting, different risk levels, such as 20-pack year smokers or 40-pack year smokers. So through coordination, the U.S. Preventive Services Task Force and ARC approached us and asked if the lung cancer CISNET groups could work with them. And through working with them collaboratively, they decided to model a range of different screening programs. So the National Lung Screening Trial criteria are shown in red, but through discussions, they decided that it should be modeled 4 different ages to begin screening, 3 different ages to end screening, 4 different minimum pack years for screening, 3 different frequencies for screening, 4 different minimum years since quit for screening, and including 2 reference criteria, that represented almost 600 criteria per sex, and if you do both genders, that's over 1,200 different runs. So a lot of computing time and a lot of collating of results. And you can imagine, the National Lung Cancer Screening Trial, I think, cost over $300 million, and nobody certainly could have spent $300 million times 600 is more money than anybody could ever spend on a trial. So it was really thinking to use the modeling and some assumptions to go beyond the trial results. So the question is, how do you sort through so many scenarios to determine the quote-unquote best ones? Well, this is the kind of plots that we produce. The y-axis, I'm going to go through this a little bit slowly. The y-axis on this plot shows the percent mortality reduction compared to no screening. And the x-axis are the number of CT screens per 100,000 population. And what we do is plot each screening regimen on this graph. And ones to the upper left represent more efficient scenarios since they save the most lives per screen. And the ones on the lower right are least efficient since they save the fewer lives per screen. The efficiency frontier represents the set of regimens that are the best we can do for each specific number of screens. That's kind of this envelope on the upper left. And so they selected as efficient, and in CISNET we selected as efficient those regimens that were on or near the efficiency frontier for at least 3 of the 5 models. So we didn't just have one of these, we had 5 of these. And so if it was close to the efficiency frontier for 3 of the 5 models, then we selected it as something that we should consider. And we show some of these, just some of these here. You can see if you look, I don't know if you see my mouse, but it says NLST. That's not, it's close to the efficiency frontier, but it's really not on it. And there are many, many choices. There are many choices on the frontier. All of them are efficient, but use a different amount of resources per lung cancer death prevented. And the task force selected this one right here, start at age 55, stop at age 80, 30 pack years, less than 15 years since quit. So how did they do that? So the first step was to see what's kind of the reasonable range of all these regimens that might be reasonable. But then came the hard choice of those that are considered efficient on this efficiency frontier. Which one should they consider selecting? And so that's really up to the task force and their kind of clinical and public health opinions. But what we needed to do was present them with some data that they could use to help make that decision and think about the trade-offs. So we provided tables like this. They said which regimens, screening regimens, protocols along the efficiency frontier they were interested in, and then we, through modeling, produced a table like this that showed the different screening scenarios, age to start, age to stop, etc. Some of the benefits, lung cancer deaths averted in terms of percentage, then the sort of resource use, total number of CT screens, but then some of the harms, radiation-induced lung cancer deaths, overdiagnosis, and then sort of a overall metric, a scaled metric, the number of CT screens per lung cancer death averted. And through their judgment, then they picked the one in yellow that I mentioned before. And the new lung cancer screening recommendations were released in, I think, December of 2013. And then there was an Annals of Internal Medicine article in December of 2014. So I hope that gives you a sense of how we worked with the task force to help them do this. There was also an evidence review that was very, very useful. But there's a number of smaller trials in Europe and different countries. But this was a situation where there was really one major trial, and CISNET helped them extrapolate from that trial, from the one screening protocol that was actually done in the trial. The second example I'm going to talk about is in colorectal cancer. The 3 modeling groups, the coordinating center is Ann Zalbert Memorial Sloan Kettering Cancer Center. So this represents another area that CISNET has worked on, and it's state and local cancer control planning. And with the support of CDC, CISNET investigators were linked up with state and local cancer control planners to see how modeling can help them with specific problems. So the colorectal group was matched with South Carolina, who had developed a program approved by the state legislature and the state legislature approved a non-recurring budget of $1 million per year for 2 years to promote and pay for colonoscopies for the uninsured. And why did they choose colonoscopy? Well, states have gravitated to colonoscopy because they're hesitant to offer what might be perceived as a lesser screening method to an already underserved population. However, they had questions about if colonoscopy was the best modality, especially given the limited budget and the time frame of the program, and also questions about the use of colonoscopy in a rural state where people may have to travel long distances to get a colonoscopy. And through CISNET modeling, they showed that the benefit of an annual FIT program for the same budget, that's $1 million over 2 years, can screen 10 times more people because the FIT test is much less expensive than a colonoscopy. They could do 2 times fewer colonoscopies because the FIT test is kind of a triage process to get to a colonoscopy, and have 4 times the number of colorectal cancer deaths prevented. So overall, this showed that the FIT screening program prevents more colorectal cancer deaths than a colonoscopy screening program when a state's budget for colorectal cancer screening supports screening only a fraction of the target population. Well, I want to talk briefly. This is not formally part of CISNET, although it's being done by the group in the Netherlands at Erasmus Medical Center. And this project is called EUtopia, and it stands for Towards Improved Screening for Breast, Cervical, and Colorectal Cancer in all of Europe, the 28 EU countries and 11 associated countries. And the phases of this project is kind of a steps of health policy cycle, monitoring, evaluation, and barrier analysis. And they first focused on just 4 exemplar countries: Finland, Slovenia, Italy, and the Netherlands. And then they helped organize an interactive workshop for all delegates for all the 28 EU countries and EU states and 11 associated countries to build capacity to conduct cancer screening evaluation independently. So this is a pretty complicated diagram. I'm not going through that. But the question is, what does it take once you develop a model for one country? First of all, what does it take to customize a model for a particular country? So if you're doing that, the full job of that, it was represented by this diagram where you have to get a lot of data. There has to be a lot of data available from that country. The models have to be customized. There has to be some calibration to the data, and then models refit, and then maybe some independent validation. So this diagram just represents it's a very long process. So maybe not too bad a process to do for 4 countries, but certainly a process that would be impractical to do for, say, 28 different countries. So that was the first step they did. They tried to pick kind of exemplar countries for around Europe, and they picked 4, and they did the full model. They calibrated the model fully to that country using all the data they could. But then what they decided is that adjustments for other countries should be much simpler. So they used a model from an exemplar country for the region. Unlike probably the United States, where we have states, it's not necessarily contiguous states in the United States that are similar to each other. But in Europe, there is some countries that are close to each other do sometimes, not always, have a similar economic status and things like that. So what they did was use that exemplar model for that region and then make kind of more what I call surface basic adjustments, not the full calibration to the background incidence level, overall participation rates, and detection rates. So try to make as many adjustments to their situation as possible, but not in a totally refined way. And just to say, so I think we're learning from this. So I think there's a lot of lessons to be learned, not necessarily doing exactly what EUtopia did, but as we try to take models that we've developed, say, in the United States and use them in other countries, or models that we've developed like in one state for South Carolina, and how, without doing a full model development, we could use them and apply them effectively in different situations. So I think we're continuing to learn on this dimension of modeling. The final cancer site I'm going to talk about is prostate cancer. We have 3 modeling groups, and that's coordinated by Ruth Etzioni at the Fred Hutchinson Cancer Research Center. And this is a sort of a different dimension of what we do modeling, and this is called metasynthesis or model-based meta-analysis. And what it is CISNET models have been used to combine trials that are too different to combine using standard meta-analysis. When you combine trials using meta-analysis, the trials have to be similar in a very basic way, similar protocol and things like that. Well, what do you do if you have results that don't meet that criteria? And we had that. What I'm going to talk about here is an example that was like that kind of big time, and that's the two major randomized trials of PSA screening. The PLCO, prostate, lung, colorectal, and ovarian screening trial, that was the trial in the U.S., had negative results. And then the European trial, the ERSPC, European Randomized Study of Screening for Prostate Cancer, that showed a 20% mortality decline for PSA screening. And these both came out in the same issue of the New England Journal of Medicine in 2009. And so we saw the picture of the tracks not meeting here. It was very frustrating because, in a sense, we want to try and make recommendations for PSA screening, and we have these 2 major trial results that disagree in a major way. Just to say some of the differences, the PLCO trial had annual screening. It had a cutoff of 4 nanograms per milliliter. There was a lot of contamination in the control arm. A lot of people in the control arm got screening because there's a lot of ambient background screening, that PSA screening that's going on. The biopsy and follow-up tests were left to individual MDs and patients to decide, even if they had a positive test, should they have a biopsy. So that varied quite a bit. In the European trial, there was screening every 4 years, a cutoff of 3 nanograms per milliliter, so less often, but a lower cutoff. There was less contamination because there was less kind of ambient screening going on. And then there was a set protocol for follow-up of the positive test. So after these results came out, the CISNET group decided, well, could we work with both trial groups? And so we arranged a collaboration. It's not always easy to do, with both trial groups to work with them, and we got permission to obtain individual level trial data from both trials. And there were 2 different, I'm going to show you 2 different results that we did that represent this kind of meta-synthesis or meta-modeling. So the first one came out in Cancer in 2017. And what it did is it started with the results of the European trial. And you can see that first dot up there represents about a 0.8 hazard mortality rate, or 20% mortality decline. And what we did systematically is model each of the things to try and taking away what was unique about the ERSPC trial, and then adding in what was sort of the certain specific qualities of the PLCO trial. So the first one, run 0, is simulating the basic European trial with and the uncertainty range represents kind of the uncertainty of the input parameters being integrated through the model in terms of the uncertainty in the output. Then what we did is take I won't go through all these, but I'll go through them quickly. Is what happened when you get rid of contamination. So when you get rid of contamination, the results get a little better. There wasn't a lot of contamination, as we said in the European trial. Then they put in 100% screen attendance, as if everybody attended. You never have that in a real trial. Then treatment and then 100% biopsy compliance, as if everybody would have gotten a biopsy. Well, that didn't change the results very much because most people who had a positive test did get a biopsy. Then treatment is in the screen arm. There was some concern in the European trial that people who didn't get PSA screening didn't get quite as good a treatment, so we adjusted for that. And then we went from a 4 years, it was changed, this is all through modeling, from a 4-year screening interval to a 1-year screening interval. Then they started adding in, so now they've kind of taken everything that's sort of very specific to the European trial. Now they started adding in things related to the PLCO trial. The type of population. So adding in African Americans, and they have higher risk of prostate cancer. Adding in some of the specific treatment that was used in the PLCO trial a little better. Then adding in the threshold of biopsy test threshold of 4. Then adding in PLCO biopsy occurrence. A lot of people didn't have biopsy, so the results went towards 1. Then PLCO screen attendance, that made the result go towards 1. And then PLCO contamination, and that made the result go towards 1. And then we just ran the base model of PLCO. And so you can see, when you think these results are apples and oranges so different, what we showed here is that the results are not necessarily inconsistent when you try to take an account for all the differences in the two studies. But this study, the one thing that we liked a lot about what we did in this study, but the one thing, this started with ERSPC and sort of went towards PLCO. We wanted to do a different type of result that was kind of symmetric, and that's where we did this second study. So in this second study, what we tried to do was quantify the intensity of early diagnosis in each arm of each study. So that's including screening, biopsy compliance, etc., to make one measure that sort of captures all those. And that measure, there's no perfect measure of that, but that measure is sort of quantified as the average time, the mean time that screening advances the time of diagnosis in each arm. We call it the mean lead time, or MLT. So in other words, what does screening do? The more screening, more PSA screening you have, and the more biopsies you have when you get a positive screen, the more you're going to find people earlier than you would have detected them earlier. And so then through modeling, what we tried to do is determine what was the mean lead time in each arm in each trial. So in the ERSPC, it was about 4 years, and in PLCO, it was about 4.1 years. And it's interesting because the ERSPC trial had a cutoff of, they did screening every 4 years, but a cutoff of 3. The PLCO trial had a screening every year and a cutoff of 4. So those two things, interestingly, just kind of balanced each other out to get a mean lead time of 4 years. In the ERSPC trial, the control arm, if there was no contamination, should have a mean lead time of 0, but there was some contamination, so the average lead time was 9/10 of a year. In PLCO, there was a lot of contamination, so much so that the mean lead time was 3 years. Okay, so then when they got these different things, so this kind of quantified the amount of screening, not just the amount of screening, but the amount of early detection in both arms of both trials. So then they modeled the time from randomization to prostate cancer death as a function of the mean lead time in each arm using individual level data in each trial. And what they found, first of all, they tested for an interaction, and they found no evidence of different effects of screening on prostate cancer mortality between the trials, a p-value for interaction of 0.37. And then they said, okay, now that we don't have an interaction, we could look at what is the impact of PSA, of early detection. And they estimated between a 28 to 35% prostate cancer mortality reduction in the European trial and 31 to 37% in the PLCO screening arm relative to no screening. And one important thing to remember about this study is this study captured was only tried to capture the benefit of screening. And of course, PSA screening is a balance of harms and benefits, and this study quantifies the benefits only. The challenge, of course, is can we come up, there's many, many harms, such as overdiagnosis, and the challenge is can we come up with a regimen of screening that best what I call threads the needle to maximize benefits and minimize harms. So this was not at all trying to capture harms, just benefits, but trying to reconcile two big expensive trials that maybe there's not many other trials that will be done of this magnitude. How can we try to take advantage of that? So finally, I just want to say, Tracy, I know I went a little long. I'm going to be done in maybe 1 more minute. Hope that's okay.
Great, thank you. If anyone has questions, please send them in the chat box to me.
And I'll be done in 1 minute. And so finally, where do modeling results fit in the evidence hierarchy? And it's a difficult question because I think evidence review groups think about this usual evidence hierarchy going all the way from systematic reviews to randomized controlled trials, all the way down to editorials and expert opinions. And a very, very difficult question is, where do modeling results fit in this hierarchy? And we had a paper that was in the Annals of Internal Medicine. I think Diana referred to a different aspect of this. And we decided, well, gee, models themselves don't fit in anywhere in the evidence hierarchy, but it depends on how much extrapolation that's we're doing from primary data. And that the credibility of results depends on the degree of extrapolation. And we just took some examples here of different levels of extrapolation, and I'll just say a few of those. So one where there's a lot of trial evidence, but not anything that specifically answers this question, but it's kind of what we might call interpolation almost, between annual and biennial mammography benefits in women ages 50 to 69. And then at the other end of the spectrum, well, an F here represents ductal carcinoma in situ, the overdiagnosis resulting from mammography screening. We're learning more, but we don't know much about the natural history of ductal carcinoma in situ. So there's the results in some of our, especially our earlier modeling results, were all over the place. And so I think we tried to quantify, just in a sort of a general way, the relationship between extrapolation from primary data and the credibility of modeling results. And I think that's how you have to place it in the evidence hierarchy. Well, thank you very much for the opportunity to talk. Sorry I went a little bit long. Here's CISNET on the web, and here's my contact information. Thank you very much.
Great. Thank you very much, Dr. Petiti and Dr. Foyer, and I apologize again to everyone for all of the technical difficulties. If you have questions, please send them to me in the chat box, and I'll ask Dr. Petiti and Dr. Foyer. Here's one question for both of you. First, perhaps Dr. Foyer, if you could respond first. In your experience, what have you seen as the major barriers to the use of modeling by policymakers and guideline makers?
Yeah, I'll just answer briefly and let Dr. Petiti answer. I think two things. One is this idea that we've tried to overcome, that you could almost get any result from modeling, and that there's not a lot of credibility to the modeling. And secondly, the difficulty of understanding, understanding the assumptions of these models, because they do admittedly have a lot of assumptions. Some are more apparent than others. And how does somebody understand all those assumptions and how credible they are?
Thank you. Dr. Petiti, do you have anything to add?
Yes. I would just emphasize that there's a great deal of difficulty of many people who are on guideline development groups in understanding the models, and in general, people who don't understand something don't want to believe it. And that certainly what was a problem that the members of the U.S. Preventive Task Force had to overcome in beginning to use models to inform their recommendations.
Thank you. Here's another question. Is there a central repository of existing models so a guideline developer could search one place to see if existing models exist? Dr. Foyer, do you want to start?
Yeah. I don't think there is. I don't know really that there is any. I think maybe you have to look in the literature. Dr. Petiti, do you want to comment on that as you've searched out, as the task force has searched out, for different types of questions, the modeling groups that they might want to use?
There isn't a central registry, and it's actually sometimes quite difficult to know whether there is a model and whether there's a good model for any given topic. Even for condition like cardiovascular disease, where the U.S. Preventive Services Task Force used a cardiovascular disease model in order to help guide its recommendations about the use of aspirin, it was quite difficult to find a model and a modeling group that they could work with on that project.
This is Tracy Wolf. I'll also add that it's sometimes challenging to use models that already exist or in the published literature because they don't often completely address the question that some policymakers or guideline makers are asking. So it can be challenging in that way as well. We have another question. Can you discuss available quality rating scales that systematic reviewers can use to assess off-the-shelf models? Dr. Petiti, do you want to answer this question?
Yes, I love this question. In fact, there have been discussions and papers written about approaches to critical appraisal of models. And people have laid out criteria that define a good model and a less good model. But there is no checklist or anything that is similar to, let's say, the PRISM or the Moose, or now more recently there's a whole checklist about assessing reports of models of predictive validity, predictive models. I actually wrote and worked with Jennifer Lynn and others to write a checklist for appraising reports of cancer screening models, and that was quite difficult because they're the models are so variable. It's something that hopefully the modeling field will continue to work on, and ultimately there will be a consensus about how you can critically appraise models and modeling studies and reports of modeling studies.
Thank you. There's another question. It seems it may have been in response to Dr. Foyer's comments about credibility. Will explaining intermodal differences result in more understanding and acceptance of models?
I think we've seen that to a large extent, already, and because I know some people, when we work with sometimes people on the task force, they came to understand some of the kind of the range of assumptions that the different models made, and they felt that there was kind of a robustness with respect to that you didn't have to buy into any particular assumption. You could that there were sort of a range of assumptions, and you could see the range of results that went into that. But also, when we have differences, when we do a systematic comparative modeling approach, we could try and explain those differences. And sometimes the differences are usually based on just a lack of understanding in the base, not a lack of problem necessarily in the modeling, but just a lack of the basic scientific understanding of things. I mentioned ductal carcinoma in situ for breast cancer, and we're gaining understanding, but there's a lot of lack of there's just a lack of basic scientific knowledge of the natural history, the preclinical natural history of ductal carcinoma in situ, and because of that, that's reflected in the results of the modeling. So it represents some of the uncertainty between the models represents basic scientific uncertainty, but it does sometimes help point out areas for further study where maybe we could narrow that gap. But in summary, I think that comparative modeling has really helped the credibility.
Dr. Petiti, do you have anything to add?
No, I don't.
Here's another question. How precise are the results on the efficiency frontier? That is it reasonable, in your opinion, to consider strategies that are close to but not on the efficiency frontier?
Yeah.
So
there's always a scatter of points, and we often take consider, we take the underlying variability into account and do try to consider strategies that are on or near the frontier to take that into account. And it would be, in some sense, it would be a shame to have a strategy that, might be very good, but just because of some of the, noise in the inputs of modeling and how it's integrated through the models, that we don't consider that. So we do consider usually a range of things that are even close to the frontier.
Dr. Petiti, do you have anything to add? One more question we have is, in your opinion, and you spoke, both of you spoke a little bit about this, but if you have anything else to add about how policymakers or guideline makers should weigh the differences between the RCTs, significant differences between the RCT findings and the modeling results, to come to some conclusions.
Yeah, maybe, Diana, do you want to take that one?
Dr. Petiti?
Did we lose her?
We may have lost her. Dr. Foyer, do you have comments?
Yeah, I think primary evidence from trials, in some sense, always has primacy. In other words, the trial results are direct empirical results. The issue is, as I talked about in prostate cancer screening, is often trial results have difficulties in interpretation. For example, when there's a lot of contamination in the control arm, or we have two major trials and they just disagree with each other, and that's where we have to go beyond that. And then also, just like I showed in the National Lung Screening Trial, there's only so many different screening regimens that we can model in trials, because trials are very expensive. So if we're trying to extrapolate from that, then it's necessary to use modeling. But trials provide primary direct evidence, and if we have direct evidence from trials that's very clear, then that data necessarily takes precedence over modeling.
Yeah, I am here, and I think that the prostate example is quite an elegant example for how models can help to clarify why models disagree, why trials disagree.
Thank you. Well, those are all the questions we have today, and we're almost out of time. So thank you very much to Dr. Foyer and Dr. Petiti for presenting, and your patience with all the technical difficulties. And thank you all who attended today. Please see the website for the recording in about a week. Thank you, everyone.